Uh, my testing. My hope my sound is coming.
Yes, you are audible.
Thank you.
Maximum
Right, Aksuma?
Sir, good afternoon, sir.
Good afternoon, Ma. How are you?
Fine, sir. How are you, sir? Sir, not able to hear.
Is that okay?
Yes. Now I am able to hear.
Thank you.
Good afternoon, Dr. Sikar.
Good afternoon, sir.
Long time.
How are you?
Good, sir. How are you, sir?
I'm doing good. I'm doing good.
Good afternoon, everyone. Just I think we need to wait for another 5 minutes. Let everyone join. Then we'll start the session. Thank you.
Sir, मैं 5 minutes कह रहा हूँ.
हाँ, ये बाहर का है. दोनों बाहर. ये वाला
फिर भी चल जाती है।
A very good afternoon to everyone. We welcome all to the fourth series of mental health dialogue on psychosocial impact of disaster and mitigation measures. I will quickly introduce the moderator for today's session. My name is Sarnu Kumar Singh, and along with me, Ms. Serin James will be the moderator, and we both work as a program coordinator for NMHS2 NIMHANS. A disaster affects the social structure and it creates an immense barrier on the usual functioning of the society. Apart from physical consequences, it also encompasses the other domains such as psychosocial dimensions. Now, let me introduce the chairperson for this session, Dr. Kasi Sekhar sir, who is working as a consultant in the Department of Psychosocial Support in Disaster Management. He has been associated with NIMHANS over the last 4 decades. We are happy to have you on board, sir. Now, I will request you to give the keynote, sir. So, Dr. Sekhar, sir, over to you, sir.
Thank you. At the outset, let me welcome nearly 100 participants who are touching base on this particular program on the psychosocial impact of disaster and mitigation. In fact, I am told that this is going to be another episode would be there probably in another 4 weeks' time. So we would refrain from climate change and mitigation processes because that's another major area of development which has come into. At the outset, let me call my colleagues, other speakers for the day, Dr. Arvind Raj from NIMANS, as well as Dr. Bhavesh from the AIMS Rajkot. Along with them, let me call one of my earlier friends, Dr. Arshad Hussain from Kashmir, from Immense Kashmir, and Dr. Gajendra Singh Sojan, Associate Professor and HOD of RIMS, Imphal. Roughly a north, south, east, west sort of a conglomeration is occurring, and a host of nearly 100 and other who are viewers who are here to have the next 1.5 hours to look at how are we going to go about it. At the outset, let me thank Dr. Girish, Dr. Prachat, as well as Dr. Lata, who had been coordinating, along with Dr. Shubhi and Ms. Jain and Sanju Singh, who had been, as a part of the NMHS survey, had been bringing it. Quickly, because of the paucity of the time and other thing, let me ask the moderators to share one of the PowerPoints for the current one.
Yes, sir. We have made Dr. Arvind sir as a co-host, so he can share from his
Okay.
computer also.
This is my presentation, no, sir?
No, mine, there was a keynote address, what they
Okay.
wanted. If something can be
Sir,
given to me.
yes, sir. Yes, sir. Yes, sir. Just want to add. Sorry to interrupt, sir. With your permission, we would like to start the session, sir. Please allow us to start the session.
Do you want the
Hello.
keynote first?
Yes, sir. Am I audible, Dr.
Yeah.
Shekhar?
Yeah.
Yes, sir. Sir, you can give your keynote address. We'll be here. We have made you the co-host. You can share the slides from your end.
The sharing is not occurring here, ma.
Okay.
Okay.
We'll check.
Just check.
Yes, sir. Sir, in that case, please share your PPT. Can you share your PPT to the group? I'll be sharing from my end.
I've gone to share now.
Okay.
Multiple participants can share simultaneously.
So you can share. The co-host and host can share. You are the co-host. You can share, sir. Just check.
I'll put it as host. There is no co-host given, ma.
To see share screen green symbol at the bottom along with mic
Yeah.
start video. Yes, sir. Just click on that and then you open your PPT. It will be shared. Just click that green button and then select your PPT.
Just 1 minute.
Yes, sir. We are able to see your screen now. You can just go to your PPT.
Sir, your PPT is minimized. You can open
Wait,
that.
wait.
Down it is.
Are you able to see?
Yes, sir. Visible.
Yeah.
Yes, sir.
Yes, sir. Just make it full
Yes.
screen if convenient
Yeah,
to you.
1 minute.
That's visible. Thank you.
Disaster always starts off with the IT systems too. No. Well, anyway, today's presentation, let's look at something on psychosocial impact of disasters and mitigation, the international profile, the India profile, disaster India profile, and then go to some of the Niman's experiences and the need for psycho. First and foremost, let me start the thing by looking at the disaster definition from the Disaster Management Act of India, wherein I want to look at more than the other things of catastrophe, mishap, calamity, or grave occurrence, the last 2 lines or the 3 lines, where it is a magnitude has to be beyond the coping capacity of the community. The psychosocial support or care or in terms of mitigation, everything comes around this last but not the least aspect of the entire thing. So psychosocial care forms a larger amount from not only the Indian Disaster Management Act, but also the international sort of thing. Now, internationally, if you want to look at a framework and other thing, between 2005 to 2015, we had the Hyogo Framework of Action, which spoke about building resilience of nations and communities to disasters. It was more inclined towards a large amount of disaster management, post-disaster management, as well as to bring in resilience among the community. But the 2015 to 2025, where we have started talking about the issues pertaining to create awareness on disaster risk reduction, came from the Hyagos and I framework of action. So that brings into focus internationally, we are looking at disaster risk reduction rather than disaster management per se, on which India had spent more than 5 decades of it when it was under the Agricultural Ministry, and after turning it over to the Home Ministry, currently under the National Disaster Management Authority, it is looked as disaster risk reduction as one of the major strategies. So disaster internationally affects both the developed as well as the developing country. And none of the country in the world is disaster free. Wherever you're, whichever country you're talking about, everything has a sort of a disaster. And the Southeast Asia is one of the regions of the world highly exposed to a variety of natural as well as human-induced disasters, hazards. And it took lives of about 500,000 people in the last decade and caused huge economic losses, massive destruction in the country's economy, loss of life, livelihood, disability due to disaster, financial problems add to the view of the problem. And population at risk includes uncared, aged, women, pregnant mothers, orphan children, single parent, as well as persons with disability. These were the traditional sort of a thing, but currently, after the pandemic, we are now seeing that there is a much larger population at risk to whom we have to address both the risk reduction as well as management aspect of it. Now, if you come back from the international scenario, having looked at the profile as well as the frameworks and other things on what we are working, India has almost 3.2 million square kilometers with 28 states and union territories with the population crossing 1.44 billion. The funniest aspect of it, as the speakers represent the north, south, east, and west, India is multi-climatic, multi-agrarian, multilingual, multi-ethnic, multi-religious. In any one of a post-disaster management, I used to see my friends from Punjabi coming and making rotis. But for a South Indian following a tsunami, rice was one of the main thing what they wanted to have rather than the chapatis. Though at the time of hunger for the first 2-3 days, they enjoyed it. On the third day, they just wanted a porridge, which is just a rice with water and a little pickle. And that too, it will be better if I have a fish being given as a pickle. Look the type of the climatic. You can't have.
Hello, Dr. Shekhar, we are not able to hear you. I think there's some problem in the network there.
Please call him.
Yeah, I think he's trying to reconnect.
There is some network issue. We are trying to connect to Kasi sir. So kindly please wait for 1 or 2 minutes. Sir is trying to reconnect again. So just I think in 1-2 minutes, I think he will be here. So kindly, please, we need to wait for him to come back. Thank you.
Hello. Dr. Sekhar is in Chennai right now. He has some network issue there. He's trying to reconnect. I think we can wait for another 2 minutes for him.
Apologies for that interruption. I think there is some network issue with
I think we have Dr. Kasi Sekhar sir with us. Sir? Sir, kindly unmute yourself.
Yeah. Are you able to hear now?
Yes,
Yes,
sir.
sir.
Yes, sir.
Yeah.
Yes, sir.
I'm sorry for this technology disaster, though all the things on the system shows everything is fine. Now you may need to go ahead without looking at the PowerPoint. I'm sorry, I'm told that we lost after the Hyogo framework. Am I right?
Yeah.
Yes,
Hello?
sir. Yes, sir.
Yes,
Yeah.
sir.
So international disaster profile, if you look at, it affects both the developed as well as the developing countries. And none of the country in the world is disaster free. Southeast Asia is one of the regions in the world highly exposed to a variety of natural as well as human-induced hazards. It has taken lives of about 500,000 people and has caused huge economic losses, massive destruction in the country's economy, loss of life as well as livelihood, disability due to the disaster, and the financial problems. Population at risk include the uncared aged, women, pregnant mothers, orphan children, single parent children, and persons with disability. But the current pandemic has shown us much larger population at risk, which we have to go along with the HRV profile of the local area, the hazard risk and vulnerability profile. Now, if you look at India profile, we have 3.2 million square kilometers, 28 states, 8 union territory population with 1.44 billion as of 2024. Now, the funniest part of it is that India is multi-climatic, multi-agrarian, multilingual, multi-ethnic, multi-religious, and following a disaster, you have to have a need of understanding the idioms of distress from the local language, culture, and gender. So an expert from somewhere else may not be able to do justice for a local situation or a local disaster or emergency. Why I'm talking about India is a theater of disaster with 8% cyclone, 12% flood, and 28% drought, 56% earthquake. Over and above that, human-made disasters like the gas tragedy, epidemic, riot, refugees, and other things also gets into picture. Now, NIMANS is a nodal center for its work done for the last 4 decades in this particular area. It was recognized as a nodal center following the tsunami in 2005 and an institution of excellence by the Ministry of Home Affairs in 2010 And then the Ministry of Health and Family Welfare sanctioned a Center for Psychosocial Support in Disaster Management in 2019. And now that has been upgraded as a department with the multidisciplinary personnel into 2022. Now, disaster and mental health experiences for us in the last 4 decades shows that there is a higher prevalence of mental health problems and morbidity at PHC and community level, high psychiatric morbidity among the survivors immediately and long-term after disaster, problems like depressed mood, sleep disturbance, preoccupation with loss, fatigability higher among the survivors. And evidence-based research has showed intervened community had low psychological distress, disability, and quality of life than the non-intervened population. Now, if you look at the tenets, why psychosocial care, apart from the definition, the last 2 lines, what I said, that it is beyond the coping capacity of the community, the area which are affected by a disaster are biopsychosocial issues. 90% of the population do have a reaction to any disaster or emergency. These reactions later on change into symptoms and mental health syndrome, and predominantly it affects the women and children. And psychosocial factors in natural and human-made disasters are different in terms of the reaction. For example, with human-made disaster, it is more a psychomotor-related anger, anguish to take revenge on the people. And also in terms of the other issues, when we talk about your intervention is going to be totally different, and the risk reduction strategies are also going to be different. And 50% of any primary healthcare seekers and 1 among all 4 in a community do have a mental health consequences subsequent to a disaster. Psychosocial intervention for survivors prevents the pathological development and help in healing the minds. So the question what I am putting in front of the group, the viewers and other thing, rebuilding a structure which has been damaged is possible within a matter of few weeks or a month or within a year. But healing of mind, is it possible where there is a loss of all the family members and the survivor is only a elderly women who keep saying the God should have taken me rather than my grandchildren and my son or daughter. So the thing boils down when there is a higher impact of event leading to distress, lesser functionality, loss of coping capacity, the social fabric being disrupted, and eroded social support, the need for psychosocial care, support, and rehabilitation becomes more important following a disaster. But building in disaster risk reduction and preparedness should be the larger motto. And the phases of it comes up in terms of psychosocial first aid and providing a spectrum of psychosocial care, followed by titrating the intervention to psychosocial support to the individuals and other thing, and intensify hazard risk vulnerability of the population for risk reduction. Develop disaster psychosocial preparedness, build resilience among the community members. Towards this, there are a large amount of policy initiatives for healing the minds today, and adequately robust Disaster Management Act guidelines for psychosocial support and mental health services in disaster management is currently in place to effectively cope with the natural and man-made disasters. We have also worked in terms of developing resilient cities through disaster risk reduction in the context of disaster and climate change in Cuttack, Vijayawada, Visakhapatnam, Shillong, and Mumbai city, each one of them having a different geographical terrain and looking at the HRV analysis and how to build in resilience. And the National Disaster Management Authority has now accepted a uniform pattern of psychosocial care and preparedness modules and IEC materials developed by NIMANS to take care of crores of people in terms of the psychosocial first aid, and reach out to large in terms of lakhs through the psychosocial support at the district level and at the state level to look at it for reaching out to thousands to various institutions, and at the national level with hundreds of institutions who are working at the emergency. These modules are now available on the NDMA website for you. And apart from that, the government is currently has taken up disaster preparedness on psychosocial support and mental health services, wherein nearly about 97 persons were trained throughout the country, except for Assam and one or two union territories. And through these master trainers, it is now trickling down to the states. And I'm happy to inform you, nearly 15 states have been taken up the capacity building program for healthcare professionals on psychosocial support in disaster management. They had been now equipped with the healthcare professionals on psychosocial skills to work with disaster survivors and integrating psychosocial care in disaster preparedness, risk reduction, resilience building, and response program. Among the healthcare sector in various states and union territories, we have so far covered about 13 and about 1,200 and odd healthcare professionals, which means there would be 4 persons per district who are trained in psychosocial support whenever a disaster occurs or in terms of risk reduction and all. Over and above this, the Government of India, Ministry of Health and Family Welfare, Emergency Disaster Management Cell, Emergency Medical Relief is also working on preparedness, disaster preparedness, and psychosocial support and mental health services on CBR and emergency, chemical, biological, radiological, nuclear emergency, seaport, and emergency handlers. And we have covered almost all the major airports in the country and the seaports in the country. Along with that, nuclear power installations in 6 of the places in the country. And look, also providing them an skill in terms of how psychosocial first aid and caring of the carers can be taken care of. And international disaster preparedness, now NIMANS is associated with the Ministry of Finance in terms of doing a rapid need assessment and a detailed need assessment and HRV analysis on psychosocial and mental health services for 10 small islands internationally. And this is followed by training of trainers. The department has completed 2 of them, one for Fiji and Philippines, with the support of Ministry of External Affairs. So the emerging contours, if I have to come to the end of it, psychosocial care is currently widely accepted and practiced as a community-based intervention model. Innovative macro-micro models of operation at grassroots, incorporating the contextual realities and cultural practices are noticed. Standardized capacity building models are available, and availability of a huge resource material on psychosocial care in regional languages is now mapped, and working with specific risk groups like children, women, disabled, and elderly has emerged. I'm very happy to note that compared to 4 decades back, the number of professionals who have got into this area is much well-being, as well as looking at the humanitarian needs, how they are looking at as a time-bound activity, but as a timeline activity and other thing. And to end, disasters keep occurring in spite of all our preparedness, mitigation measures and all. Let me conclude that there is a need for professional, personal, policymakers and public commitment to emerging issues and to make it a much larger agenda in terms of a public health issue in the future to come in. Thank you very much. I'm really sorry that the PowerPoint could not be shared, and it will be shared through the group later.
Thank you, sir, so much. And we appreciate your effort to make all the things present to all the members in this webinar. So thank you so much for your valuable insight on this particular topic, sir. And sir, we seek your permission to invite our first speaker. So thank you.
Saying one small request.
Yes, sir.
I'll try, because of this instability in the network. If I'm not able to, probably one of you may need to conclude with the observations. I'll try to be as much as possible.
Sure, sir. Sure, sir. Thank you so much, sir. So, without ado, we would like to start the session with our first speaker, Dr. E. Arvind Das, sir, who is additional professor at Department of Psychosocial Work, NIMHANS. Sir, over to you, sir.
Thank you, Sanu. Let me first share my presentation. Can you allow me to share?
Sir, you are not able to share from your side? So 1 minute, I will check.
Yes, I can. I'm sorry.
Yes, sir. Yes, sir. Please.
easily otherwise.
Yeah, is my screen visible?
No, sir. As of yes, sir. Now it's visible, sir.
Yeah.
Yes, sir. It's clearly visible.
Yes. Good evening, one and all. It's pleasure to meet you all in this mental health dialogue to talk about psychosocial impact and care during disasters. From what Dr. Shekhar has left, let me continue on this disaster psychosocial care aspects from community-based model. As it was told in Disaster Management Act, even the international definitions on disaster focus more on the psychosocial aspects rather than just the ecological or the economic impact what is happening around the disasters. And with regard to the earlier scenario of disaster mental health services, it was more towards the curative services where we go there, diagnose persons, and then treat them through medications, which was not actually working. And that's the reason the whole perspective has changed into disaster psychosocial care, where it is just not about working on the individuals, but it is also about dealing with the broad range of psychosocial issues, and most importantly focusing on the independence and dignity of not just the individuals but also the families and groups. So it also serves to prevent pathologic developments and further social dislocation. So compared to the disaster mental health per se, where we treat only the disorders caused by a disaster, this is a holistic sort of approach to cater to the all the population who's affected in disaster. And some of the disaster mental health principles, which was released by SAMHSA way back in 2000, it talks about the important aspects like not even a single person is untouched by any disaster, whether you are directly affected or you are watching the disaster scenario in televisions and other news. Definitely in one way or the other we get affected. And also, more than the individual trauma, there is a collective trauma in that particular family or the community. Yes, people pull together to work and to get out of that particular distress, and because of the larger impact their effectiveness is diminished, and because of which they require support from outside. And please remember, these are all the whatever the emotional reactions and the psychological reactions what being faced by the individuals and the community. These are all the normal responses in a given abnormal situation. Abnormal situation being the hazard or the disaster itself. And the most of the emotional reactions are not caused just by the hazard. It's just not by the earthquake or the flood, but it is because of the living issues or the problems which are caused followed by that particular hazard, that creates more of emotional reactions. And then we also must understand, as Dr. Shekhar was saying, all these services cannot be a ready-made sort of thing. Even in one particular state, one region to the other region, these disaster mental health services should be uniquely tailored. As well as the survivor, we also need to understand, definitely survivors will respond, if not immediately. Our continuous care will make them to respond to our active interest and concern, and the interventions must be always appropriate to different phases of disaster. It cannot be the same across the different phases. And of course, the support system, the external support system and the internal support system are very crucial for the recovery. Keeping these principles of disaster mental health in mind, some of the interventions which are being designed and followed by institutes like NIMANS across the country are many. And also, as it was discussed, now we are more focusing on disaster risk reduction, how we can mitigate, or how we can mitigate the natural disaster, how we can prevent human made disasters. So all the interventions, including psychosocial support and mental health interventions, are more focusing on this disaster risk reduction. But that does not mean we are not focusing on the prevention or response. Obviously, the disaster risk reduction also includes the rescue, relief, rehabilitation and reconstruction phases. Only thing is here we prepare the community to get into all these kind of services even much before the incident happens. Having known this particular model of disaster risk reduction and some of the principles, let us understand what are the major impact in terms of psychosocial impact. As we all know, there are different lifestyle changes which happens followed by a disaster, which includes increased use of substance, family violence. Even in the recent COVID-19 scenario, we could see a lot of violence in the context of family, wife battering, neglect of children, not purposefully. Probably they are more busy in getting their relief materials, looking out for things what they have lost. In that process, knowingly or unknowingly, there's a lot of neglect towards children. And with regard to adolescents, definitely there is a deviant behavior because there is no much of care and protection. There are chances for them, even to some extent, they being involved in mob behavior or some sort of processions being taken up by the community, where the adolescent children become vulnerable for such activities. And when it comes to social issues, yes, a lot of displacement, unemployment, single parent families, women who become widows, a disruption in the social fabric. There you can see a lot of even clashes even between the neighbors for not able to get the relief materials, and also the breakdown of the traditional forms of social support. If when there is a death happening in a home, there are people generally around our house, people will come in for support, whereas in disaster situation things are totally different. And since it becomes beyond their coping capacity, there requires the external support. And when it comes to economic issues, there it is just not about the direct economic impact for the survivors themselves. There are also larger indirect economic impact in terms of spending lots of money towards these disaster affected communities. So there are disaster economic impacts most at the micro level as well as at the macro level. And all these economic and social impact as well as the lifestyle changes also are because of some of the psychological issues, and or the other way, because of these psychological issues they also get into some of the economic. For example, whenever I'm stressed and I lack interest in doing any of the activities, obviously there will be more economic impact. And then because of the economic impact, I'll be more feeling helpless, hopeless. So this particular types of impact, one can use it for both psychosocial analysis from time to time, as well as to understand what exactly is the source of the problem for the individual or the family or the community per se, and we can start working towards the source of the problem. And as discussed already, some of the survivors who are at risk, it doesn't mean that other types of survivors are not at risk. Comparatively, women, persons with disability, as well as children and elderly persons are more vulnerable for any any kind of disasters. So in the process of providing psychosocial care services in different sectors, the focus on these vulnerable sectors, well, vulnerable population itself is one step ahead in the provision of any sorts of services during disaster. And yes, the mental health resources are much lesser even in normal situation, and among them the number of professionals who are trained in psychosocial support, even among mental health professionals, are very very minimal. And even if they are mental health professionals, their knowledge about their role in the scenario of disaster mental health and psychosocial care is much much less. And that's the reason we need to focus on the community level resources, which includes many sectors, which includes college students, PRI members, youth club, PHC workers, teachers, Anganwadi workers, NGO workers, many. And these are not the exhaustive list. It depends on the community to community. By focusing on these resources in the community, we can address many of the needs. And let us see the nature of the needs of the survivors over a period of time. And all these, over a period of time, whatever the needs which are seen during the rescue and relief phase is more like a tip of the iceberg, which is more to do with the basic needs. Of course, psychosocial needs are also equally important during that time, but over a period of time, the basic needs are the one which requires less attention, and the psychosocial and mental health needs are the one, for example, in terms of restoration, rehabilitation, reassurance. These are the things which happens or which requires over a period of time. So let us not just stop addressing only the basic needs in terms of food, shelter, and clothing, because many a times people who are going to help survivors do the same mistake of just providing these basic needs even over a period of time after a year or so, and that makes them more dependent towards the people who are providing services. So this is something which we need to keep in mind. And number of professional caregivers reduces over a period of time, and that's exactly why we need to self-sustain the resources which are there in the community by training them on psychosocial support and mental health services. And when it comes to different phases, first phase, according to the phase, first, response and rehabilitation. Response includes rescue and relief phase, which is towards till the month of till 3 months, rescue and relief, and rehabilitation almost towards 1 year, where we are talking about psychological first aid and psychosocial support. Just give me 3 to 5 minutes if you don't mind, then I will be able to complete the session. Now, when it comes to psychological first aid, the psychological first aid is more to do with, reconnecting them, connecting them to the social support networks available, and enhancing immediate and ongoing safety depending on different disasters, trying to make the survivors calm and oriented to the situation, because they'll be overwhelmed with a lot of reactions. And that's where this particular phase, for the first 1 week or so, the psychosocial or psychological first aid is very, very important. And the more we provide psychosocial first aid, then the psychosocial support and care using various techniques, like helping them to ventilate, whether individually or as a group, listening to them actively, being very empathetic. Just going and giving them 500 rupees immediately may be a sign of sympathy, but what happens is they just take that to the wine shops and use it just to consume alcohol. Empathy is based on what they require, providing them the help accordingly, just to an example, and then trying to externalize their interest by involving them in various community-based activities, like there will be temporary shelters being built, or even community kitchens, involving them rather than we getting into all such activities. Maybe we might do a kind of supervisory activities, and trying to bring in the social support at all the levels, which includes individual level, focus on the individual level, focus on the family level, as well as focus on the community level. It is just not about building the temporary shelters or houses, but also how do we build the lives of individuals and the family. That should be the focus, and that is possible by using these techniques. And when it comes to children, same techniques using different mediums, making them to draw how they feel, making them to draw what they want to become in future, different types of mediums which can be used based on the age group, that we will be able to help them to normalize their reaction. When it comes to psychosocial competence, once when we finish this particular cycle, we always need to get into the psychosocial competence rather than only talking about their distress. How it can be built, focus on life skills education for children, for student enrichment, adolescent youth development, family enrichment for the families, positive parenting, and in the community, positive mental health. These are some of the areas which can be focused during the psychosocial competence phase, reconstruction phase. And these are some of the manuals which we had developed from Department of Psychiatric Social Work on these areas. And when it comes to psychosocial preparedness, Psychosocial preparedness should be a kind of culture in disaster risk reduction, and preparedness reduces a lot of cost in terms of response and recovery in any disaster situation. Basically preparing different communities, which includes government functionaries, NGO functionaries, as Dr. Shekhar was discussing, different level at state and national level, that helps them to be prepared. And what exactly, like hazard vulnerability mapping, what are all the vulnerabilities? When it comes to vulnerability in terms of physical vulnerability, people are well aware. When it comes to psychosocial vulnerability, what are all the issues which we can focus? Non-availability of open, these are all the vulnerabilities when it comes to psychosocial vulnerabilities in terms of socioeconomic status, level of awareness, amount of mental health facilities available, amount of trained manpower in a community. All these things can be mapped, and not just the vulnerabilities, also the resource maps. How many people are there around, so that they can be prepared even as part of the preparedness phase. So this is something what we can do as part of preparedness. Now, just to sum up, this is what I would like to say. Psychosocial impact, need assessment and psychosocial care services starts at the preparedness level. Provision of psychosocial care and mental health services, it starts at the preparedness level in terms of mapping, capacity building for different sectors, and mapping what vulnerabilities as well as resources. Then community will be much prepared to assess the psychosocial impact and provide psychosocial services on all these lines, and so that we can rebuild the lives of the survivors, family and community. Unlike other disaster management services, here it is more important to monitor, evaluate, and then document. It's easy to take a photograph of a newly built house to show how it was before and how it is now. But when it comes to psychosocial support effectiveness, a lot of things, qualitative and quantitative aspects, has to be documented, and that has to be given importance from the time of preparedness till the time of psychosocial competence. So I'll stop here by giving this framework. Thank you very much for this opportunity.
Thank you, sir, for such a well-researched and thoughtful delivered presentation. So thanks a lot.
Yeah.
Before going, just a small request from all the speakers, because we can go through all the informative things for a whole day, but still we are having time constraints. So we request all the speakers to be constrained to the time limit. So
sorry, I've taken 5 more minutes. Sorry.
Sir, it's okay, sir. Fine, sir. So now I request Serin James to take over and proceed the session. Serin, over to you.
Thank you, Sanu. Greetings, everyone. So now we are moving to our next speaker for the day. He is Kashmir's noted mental health specialist, Dr. Arshad Hussain, Professor of Psychiatry at Institute of Mental Health and Neurosciences, Kashmir. As a renowned psychiatrist, he will be sharing with us his thoughts on disaster, culture, and trauma. We are eager to hear your perspective, sir. Kindly proceed.
Thank you, Sherry. Thank you, Imans, and thank you, Lisa, for inviting me. Very good afternoon. It's a pleasure first that I could meet Dr. Shekhar. Online, we have met after a long time. We know each other's disaster work because right from the 2000 when I actually joined the psychiatry, somebody who I have identified with in the disaster work, Dr. Shekhar. Dr. Arvind actually took us through all the events and psychosocial impact of the disasters. We probably know the definition of disaster as well at this point of time. But I will be because what happens is that when we do repetitions of the same thing, we keep on looking at the disasters through the same angle. While I agree with whatever Dr. Shekhar says and whatever Dr. Arvind said, but I try to make it from a very different angle, and more from the experiences which I had from the old disaster work for the last 24 years, which also has a lot of events actually.
Hello, sir. Sorry to interrupt. Your voice is echoing. If you're able to connect to better network, it will be on.
Give me a minute. Give me a minute. Voice.
Sure, sir. Sure, sir.
Is it fine now? Is it better? Is it better now?
Yeah, it's
Sir,
better. It's better.
Right. So, when I joined the cafe, which is 2000, as you know, that this part of the world actually was going through a lot of trauma. So trauma was one of the things which we used to live on day-to-day basis. So just 90 days past, as well. So we usually encounter, terms like post-traumatic stress disorder, disaster, man-made disaster. So, our department as Psychosocial was something which became probably in India one of the departments where we started looking at disaster mitigation, psychosocial work from lots of angles. I myself started working with psychosocial programs of missile science frontiers, accelerating transfer, besides being in the department because there were not many psychiatrists. We were actually 3 psychiatrists. There were 2 psychiatrists and a postgraduate, and things were not looking that good. So we started working at disaster. Luckily for me, I got training from somebody who's identified with trauma and disaster, based in Vanderbilt of Boston Trauma Center. And we started, doing the psychosocial work in trauma at that point of time. When all of us do talk about disaster and its impact, many of us do not look at the definition wherein a lot of trust has been placed on coping and resilience. If you look for disaster in any community, and many of the studies, you will not find number of people. If you start looking at the studies which are done beyond 6 months, you will not look at many of the people, particularly in the national disasters, struggling to what we call as mental health issues. Coping and resilience mechanisms are inbuilt in the communities particularly for the natural disasters. There might be cultural differences across, but in most of the cultures where cultures are preserved, you'll see that the coping and resilience mechanism is embedded. Many of you who have worked with trauma will understand that the definition of trauma actually talks about an event which is a trauma. If you look at Southeast Asian communities, they do not perceive events, natural events, particularly the natural events, as disaster. They perceive these events as destined. And this perception per se has a lot to do with how the communities cope with the natural disasters. My experience with the 3 natural disasters during this time, one is a snowstorm in Baltimore, another was the earthquake of October 8, 2005, and another was the flood disaster. In all of these disasters, what we found out that while there is so-called symptomatology present in first 3 months of the disaster, but while these 3 months go on and the community culture actually works in its own way and means, post 6 months, if you again do the assessment, there's not much to actually do. Most of the disaster work actually should focus on what everybody of us agreed on TLC, gender allowance here, which actually includes the helping and rebuilding, doing the basic things, Dr. Saker talked about food, they might look very different from the psychosocial care, but they're all part of the care. So all work should actually focus on that kind of care. Rather than actually, what I saw in the doctors, people actually flooding in, coming with lots of therapists, lots of psychiatrists, coming with lots of medicines, that's probably actually not needed. And I'm dividing the word for this. This is called masterly inactivity. Masterly inactivity. I know once working low and read the surgical textbook, there's a problem called umbilical hernia. And there's a hernia in the umbilicus. And the treatment of that is masterly. You just look at this with the masterly inactivity. But most of the mental health professionals, they should let the community cope and be resilient in terms of natural disasters, particularly, rather than intervening unnecessary interventions. They should look at greater policies of this standard law and care that humanitarian aid being pushed in a way that helps people to cope and resilient, rather than actually makes traumas to be extreme. For example, sympathies of using communities and using communities after disaster in rebuilding, rather than actually lacking community trust and relief workers coming from outside. The two, if we do have two disasters in one, we let the community actually do the rebuilding, and then another we get the workers from outside to do the rebuilding. You will see that there will be different psychosocial outcomes in the two communities. That's why it's very important, probably, for the mental health professionals to, at a large level of policy making, to make policies in a way that the disaster mitigation is done in the right ways. But it's also important for mental health workers to understand that masterly inactivities is more beneficial than actually interventions many times in particular natural disasters. Now, what is human? If you look at evolutionary history of humans, we are actually made to live and cope with disasters. We are existing on this earth not because of our physical prowess, but because of our ability to cope with trauma, to cope with disasters. That is not that here now. That is not that very powerful. They did not have the capacity. For instance, tell us the existence of humans, the spirit of the cultures, tell us that we exist because we have tremendous capacity to be cope and to be resilient in front of trauma. And that actually needs to be extended. We as mental health professionals, we need to actually further the cause of that. That totally needs to be further. Rather than actually interventions which might have been tried in places where cultures do not exist. The places where cultures exist, they have historical knowledge of how to actually cope with community. Both Sagar and me have actually discussed this many times, and we both agree that how communities have inbuilt mechanisms of coping with resilience. So the first thing of that the coping with resilience of communities has to be disrupted, but it does not go away completely. The coping with resilience mechanism is still to come into play, and we let communities recover from these traumas and learn and actually make amendments within themselves. So it's very important to understand the professionals and for the psychosocial workers to understand the resilience to coping whenever we actually do tools in basketball. And we have to identify that, and we have to actually give that the value it actually deserves, and let communities actually strengthen the community structures so that the resilience is culture. So that's in terms of the natural disasters. But I also understand as mental health professional, because I've seen the man-made disasters, that lots of work probably needs to be done by mental health professionals in terms of preventing the man-made disasters. There are two modifiable factors, very well identified, well recognized, which will prevent mental health morbidities, is actually violence and drugs. If these two things are modified, there will be lots of mental health morbidity which actually might be mitigated. You might not have that kind of morbidity. So lots of the pain disaster work needs to be done in terms of trauma. But once man-made traumas are faced, and if they are immassive, even man-made disasters, which I've seen, the total resilience in the cultures of the world, there is going to be release mechanisms in the website that they actually have the but at large extent. But then the kind of mobility is there, and natural disasters, if compared, is different. Man-made disasters, because the cultures per se might be disturbed. And when the culture totally gets disturbed, it becomes a double-edged sword. So you have a culture disturbed, right from the whole resilience support is actually gone, and then the continuous chronic trauma is happening. And that's why probably builds capacity to actually deal with that might lessen, and we might have mental health comorbidities, which actually are of more extent than happen in the natural disasters. So lots of work probably needs to be done in that direction. As the theme of 26th January was invest in prevention. But if we invest in prevention, we need to invest in the answer. We need to invest in that will help probably as mental health professionals to deal with the drastic psychosocial issues in my way. That is starting difference. But saying all this, I still understand that mental health, with this I would agree that, I think we have the limitation of the time. As mental health professionals, we still do have a psychosocial mitigation groups. We need to identify that tool, we need to have awareness of that tool, and we have to actually transform all that when we do that work. We need to look at our own cultures and culture specific jobs and culture specific policies so that we do more harm and we let totally the biggest mechanisms the communities to go and further. Thank you so much for allowing me speak on this topic.
Thank you, sir. It was indeed a thought-provoking and informative talk. Now, without any delay, I'll invite our next speaker, Dr. Gurjendra Singh, Associate Professor and Head of Psychiatry at Regional Institute of Medical Sciences, Imphal. With over 20 years of dedicated service in mental health, he has made significant contributions in addiction medicine as well as in community psychiatry. Today, he will be discussing with us the mental health outcomes due to disasters and mitigation measures. Over to you, sir.
Good evening, everyone. Ma'am, can you hear me?
Yes, sir, you're on.
Thank you, ma'am. My topic is psychosocial impact of disaster and mitigation measures. Before, at the outset, I'd like to thank Disaster Mental Health Manual and prepared by Assam State Disaster Management Authority, and the authors are Suresh Badamat and Maithili Hazarika for preparing this wonderful piece of document. All the Neman's team, all the PIs, co-PIs, all the participants. I'm not going to define what is disaster, what are the types of disaster. It's a natural and man-made. The problem is that what is the importance of addressing psychosocial impacts after each and every disaster? We understand that there is short-term impacts like psychosocial impact such as numbness feeling, then sleep disturbance, acute anxiety. There's long-term psychological impacts, so many ways like PTSD, depression, suicidal these things. And that's why it is very important to discuss this particular topic in the relevance of disaster management. As we understand that after each every psychosocial impact, there are certain normal human responses. We call it grief reactions. There are certain stages of this grief reaction that we all go through those 5 stages: denial, anger, disbelief, and depression, then acceptance. This is all normal response. Normally, usually by couple of months, usually within 6 months, this particular reaction subsides. But in certain conditions, what is called abnormal human responses to particular disasters, like we call it complicated grief reactions, which is delayed, sometimes exploding in nature, and it continues more than a year. If you see the morbidity, mental health morbidity in disaster-affected population, usually the prevalence varies, but what we understand is that it is almost 2-3 times of higher prevalence than the general populations. What we come across particular psychiatric morbidity in all this, any kind of disaster, is that usually there's adjustment problems. We call it adjustment disorders. There's depression, mild, moderate, severe, and the long-term consequence of post-traumatic stress disorder, some anxiety disorders such as general anxiety disorder, panic anxiety, phobic anxiety, all kinds of anxiety disorders. And there's another issue with this is that increased use of substance abuse, especially alcohol and other psychoactive substances, as a coping mechanism. There are certain high-risk groups: women, children, and elderly, and there's already those who are disabled psychologically and physically, and those who are existing some kind of already on some psychiatric manifestations or psychiatric diagnosis, such as depression, mood disorder. They're more prone for more what you call mental issues. Then substance users, already those are on substance use. And especially I talk about disaster rescue workers. They're very high risks of having psychiatric morbidity. If you see that what are there are certain some phases in disaster mental health. We call it heroic phase, honeymoon phase, disillusionment phase, or restoration phase. I'll talk about this in this particular diagram. If you see that various phases of disaster, and there's a role of mental health professionals, that's called heroic phase. When a disaster happens, in the early stage, in the first week or so, there is so many helping hands. Community come together to help those who are in suffering and those who are having in distress in disaster, then rescue operations, so many things happening. That's called heroic phase. Then there's called honeymoon phase. Here, when the disaster happens, there are lots of rescue activity takes place. There's lots of publicity, media attention, then from the government, NGO sectors. That's called honeymoon phase. That time, people might think that, yes, communities with us, they're trying to help us. We are together. This feeling comes. Then that lasts around 8 weeks usually. Then that's called disillusionment phase. That's the most important phase in the management of psychiatric morbidity after each and every disaster. Here, this gradually, that attention of media, then attention of various NGO sectors, where government, what you call government health, or not only that, politicians, those tall promises, everything gradually fades off, particularly this phase. And here is many of these persons who are in distress, they suffer from major psychiatric problems. So this is a stage we need to act. That's called restoration phase. And the other important thing I'd like to mention here is that that we need to think about those what are called relief workers for their good mental health. So that's the principles normally we use in disaster mental health: preventive approach and community-based interventions. So we should focus on particular R6RS. RS, that's called preparedness for any disaster to happen, then immediate action, the sustained rescue work, then rehabilitation, long-term remedial measures using community resources. Then we need to try about recovery, that's returning to normal, and the resilience, community resilience, by fostering all those activities that will help community resilience. So what is the role of mental health professionals here? And it's not only giving the treatment, it's all about educating and training all the community workers, the leaders, then teachers, then other doctors, then other personnel who would be working as a team, as a collective way, as a team in these rescue operations. Then you need to have rapid assessment of the situation, psychological issues, then other physical what to call problems, then providing care and to capacitate that all the persons who are working for the betterment of what to call community, betterment of the psychosocial improvement in the community. That I'm not going to details in what you call psychological first aid. It's like medical first aid. Here, what to usually do is that we need to commonly talk, associate with the person who are in distress. We need to listen to them. We need to be a part of their this in present situation. Then that's called debriefing. Then after certain this thing, it usually takes place is a group, what to call group meetings that should take place within the 36 to 72 hours. Here, in that what you call the particular group of people, they come together and they share their experiences and they talk about that real what you call problems of this particular catastrophe. There is called trauma-based cognitive behavioral therapy and other interventions such as EMDR and what you call counselings are very good in psychosocial interventions. Then in community-based intervention, we need to have structured daily activities for children, especially in that relief camps or other settings. Then we need to foster culture and religious rituals to come down or to be a part of their what you call daily activities. There should be group discussions and the various members of that particular group. Then that's called art therapy, which is very good for children. They're asked to draw some painting, some diagram, some art, and there is a debriefing was done. So there is a public health approach. This is called three-tiered approach: universal preventive interventions, then short-term interventions, long-term intensive interventions. Here, we need to provide universal preventive interventions such as information through the internet, then through the smartphones, so that it can reach to the whole population. Then short-term intervention that lasts 1 to 3 months. Then long-term intervention, it lasts 3 to maybe a couple of years. So promoting resilience, promoting factors that causes good resilience to the community, the cohesive community. We should have a very cohesiveness among the members of the community. There will be more social networks so that we can interact with each other. There should be family support from the family members. Then we need to have some spiritual beliefs that will promote resilience in the what you call survivors of the disaster. So there are certain challenges and considerations. There's a limited mental health infrastructure in developing countries, need for culturally appropriate interventions, importance of long-term care and follow-up. To conclude, there will be huge paradigm shift from the relief-centric approach to the more what you call integrated, collective and holistic approach to deal with psychosocial aspects after disaster. There will be more emphasis on preparedness, preventive, and community empowerment. Thank you.
Thank you, Dr. Gojendra. It was really a clear and concise presentation, and thank you for sharing your valuable insights with us. Now we are moving on to the final session of the day. We have Dr. Bhavesh Modi with us, Professor, Department of Community and Family Medicine at AIIMS Rajkot. With over 20 years of experience in teaching, program management, research, and administration, he has significantly contributed to the field of public health. We would request Dr. Bhavesh to share his insights on primary health care of mental health during disaster. Over to you, Doctor.
Oh, thank you, Sherry, and respected chairperson, colleagues, Director Ames Devkar, and dear participants. Just to continue where Dr. Gajendra ended with the challenges of mental health about limited infrastructure. And as we know, there is huge need. If we look at the epidemiological transition of India disease burden from 1990 to 2015, till 1990, our two-thirds of the morbidity and mortality was from the communicable disease and maternal child health. If we look at current data, our two-thirds morbidity mortality is from non-communicable diseases, including mental health. And that is the reason in the last health policy of India, the entire restructuring of the primary healthcare has been done. And under the umbrella of Ayushman Bharat, in addition to the most popular PMJ, which is providing tertiary health medical services at the hospital, a huge component of preventive and promotive care has been added in the primary health care by restructuring and rebranding this as Health and Wellness Center, which is recently renamed as Arogya Mandir. But it's basically sub-center and PHCs upgraded to provide comprehensive primary health care. Now, what is primary health care? I will just stick to the basics in the view of limitation of time. It is an essential health care made universally accessible to the individual, which is acceptable to them with their full participation and at the cost country and community can afford. So this is one such interesting thing which recent health policy is taking care of by upgrading the PHC and subcenter and putting a very important cadre of community health officer at this center who are not only able to do what earlier subcenters were doing about maternal child health and communicable disease, but also able to take care of non-communicable disease. And as mentioned in the essential comprehensive this health and wellness center is screening and basic management of mental health ailments. So as we know, a lot of mental health problems can be easily tackled, which are general like sleep disorder, substance abuse. In case of disaster, maybe sometime anxiety. And whenever disaster happen, as we know, two-thirds of the mortality of the disaster is happening in low and middle income country. And we don't have a lot of psychiatrists or specialists. If we look at the data, in India, less than 9,000 mental health specialists are registered with MCI. And if we look at the entire pyramid of the specialists, in addition to 700 plus medical colleges and 2,000 district hospitals, 5,600 CHCs, we have 30,000 plus PHC and 1,60,000 subcenters. So out of this PHC and subcenter of around 1.8 lakh, almost 1.6 lakh are upgraded to health and wellness center. And at this center, this is the cadre which is excellently taking care of not only immunization program, but also regularly screening for hypertension, regularly checking the RBS. They are also conducting the yoga and meditation session. And they are so much respected and acceptable to the community because they are mostly living there from that community. They are even sharing and even compliance to the NCD has improved. And that is another issue with the mental health system currently. There is a lot of stigma and discrimination attached when someone goes to the mental hospital. We have seen under the HIV control program, we have voluntary counseling and testing center. The identity of HIV positive was only with the counselor, even treating doctor was knowing. We were saying there is confidentiality, nobody will come to know about HIV status. But that was the center providing service to the only HIV positive patient. So it was very difficult to keep the identity confidential. So then we shifted name from VCTC to ICTC, Integrated Counseling Testing Center, when in addition to HIV positive, when antenatal mother started going, TB patients started going, so the stigma reduced and it is normalized. Same way, if we want to reduce the stigma, we want to also ensure the mental health services are easily accessible, available, especially during disaster. Because when there is natural disaster, it takes few hours to few weeks for specialists to reach there. The first level available and accessible person is the people who are staying there, this community health officer, Anganwadi workers, ASHA, or primary healthcare medical officer. So if we can train them for the routine mental health thing, then they will be first contact point even for during the disaster and take care of a lot of basic self-care related or psychosocial first aid services. Already NIMANS and National Mental Health Authority has prepared modules for that. I congratulate them for those who released in March 23. However, it's a long way to go while the modules reaches to the last mile. And I would appreciate if the Nizam teams, if required, we all can support for that, can come out with the simple modules and SOP for the community health officer or a field worker, frontline worker or PHC medical officer. Like right now, they have to treat the TB patient, they have to just see the algorithm and manage it. Now, if they have to treat the hypertension, they can see the algorithm and do that. So a lot of screening and local management for anxiety, depression, sleep, and substance abuse can be done by them during routine as well as in the disaster. And whenever required, they are well connected through telemedicine or telemanas. And if required, once a month, a referral can also happen. So that will make the thing more accessible, acceptable, culturally acceptable, as well as very cost effective for everyone. So I'm just concluding my talk with that. That if we can integrate mental health in the primary health services and we can empower with basic tools to the frontline health worker, it will make it easily accessible, acceptable to the people, which much lower cost and ultimately reduce burden of the mental health services and reduce stigma by normalizing it. Because everybody, antenatal mother or vaccination or TB or hypertension patient is already going there. And these are the vulnerable group who are more prone to mental health issues in the disaster also. And if the same care provider, by maintaining confidentiality, confidence, culturally acceptable thing, it will be easily accessible and acceptable to all. So, thank you.
Thank you, Doctor. Thank you for your sharing your expertise with us. It was an informative session. You explained us about the role of PhD in integrating the mental health during the disaster. Thank you for that. Now I will hand over the session to Mr. Sanu. Sanu, please take over.
Thank you, Ms. Serin. As we can see that our respected chairperson, Dr. Kasi Sekhar, is not available due to some network issue, but still, we thank from our end. So therefore, that efforts he has taken him to come to the webinar and put his thoughts and insights on this topic. So moving further, I request. We would like to request Dr. Prajit, Associate Professor, Department of Epidemiology, NIMHANS, and Dr. Lata K, who is Associate Professor, Department of Mental Health Education, NIMHANS, to take over. Sir and ma'am, over to you.
Thank you, Sanu, and thank you, team, for including us into this National Mental Health Dialogue Series 4. On the psychosocial impact of disaster and mitigation measures. We had 4 important sessions on various important topics related to the psychosocial impact on disaster and also the mitigation. So I would like to just summarize few important aspects which were discussed during today's webinar. So starting with the keynote address by Dr. Shekhar, who stressed on rebuilding the structure is more easier and also possibilities are higher, whereas healing of minds is little more complex and requires a lot more efforts and also needs a lot more work in terms of preparedness and also mitigation efforts. And also thank you to Sir for sharing his real life scenarios and also sharing some incidents and also putting up the overview of various upcoming initiatives in the area of disaster in terms of the activities which are being in place for disaster prevention in airports, seaports, and also the international disaster preparedness. Then moving ahead with a topic on psychosocial impact and care by Dr. Arvind Raj. Thank you very much, sir. You have covered comprehensively about the survivors at risk and also the role of community volunteers, especially how the volunteers could actually pitch in and what is the importance of training the community volunteers in handling disaster mitigation and also providing the psychosocial support. And also another important aspect was about the stressing on the importance of psychosocial first aid, on reconnecting, and also various techniques and also mediums based on various populations and also age groups. And also, sir, one more important aspect was you stressed on the importance of self-sustaining resources and also measures. So I think that will actually take us like way forward. So thank you very much for your insights. Then moving ahead, we had a talk by Dr. Arshad Hussain on disaster culture and trauma. Thank you very much, sir. You have rightly highlighted on the importance of the coping and the resilience among the populations, especially for natural disasters as well as man-made disasters. And also the man-made, in terms of man-made disasters, there is a long way to still go, because until unless there is preventive measures in place, it will be very, very difficult to reduce the mental morbidity. So the take-home message from Dr. Arshad was that we have to actually invest in prevention, the same which was actually the theme for drug trafficking and illicit drug usage. So sir stressed on the importance of investing in prevention for reducing the mental morbidity. So thank you very much, sir. Moving ahead, we had Dr. Gajendra Singh, who spoke on impact of disaster and also mitigation measures. And he rightly highlighted the key role of mental health professionals at various phases of disaster, and also even at community level, how these mental health professionals could actually pitch in and provide the right kind of support in order to help initiate the mitigation measures. So thank you very much, sir. And finally, Dr. Bhavesh Modi, who spoke on the importance of primary healthcare of mental health during disaster. So he mainly highlighted on the importance of the measures for reducing the stigma with respect to mental health. And he also shared an example of the model of ICTC, where it is now an integrated approach rather than a disease specific or an individual specific approach. So similarly, sir highlighted the importance of or maybe the work to go in terms of like developing simpler tools for screening and treatment for various mental health conditions, and which could be culturally acceptable and cost effective, so that we actually initiate a lot of measures, especially during such disaster situations, in reducing the mental morbidity. So overall, I think all of our viewers had a great experience today listening to all our speakers, and also Dr. Shekhar sir's keynote address. I would again like to thank all the organizers, and I would invite the participants for any questions. And also I would like to request my co-host, Dr. Prachet, if he has anything to share. Thank you.
Thank you, Dr. Lata, for summing up the entire proceeding in such an elaborate manner. So we'd be happy to have any questions here to our eminent resource person. You could even please put it up on the chat box. Once again, I would extend our gratitude to our eminent resource person, starting from our keynote speaker, Dr. K. Shekhar, our resource persons, Dr. E. Arvind Raj, Dr. Bhavesh Modi, and Dr. Arshad Hussain and Dr. Gojendra Singh. I would like to thank you all for sharing your valuable insights, and I hope we had a very fruitful mental health dialogue. I also extend our gratitude to the entire organizing team, Dr. Shubhi, Dr. Cheryl, Dr. Sanu, and the entire NMHS team. And our gratitude to Dr. N. Girish, Professor of Epidemiology in Health, for the opportunity provided. So I request all the resource persons and the organizing team to please turn on your camera. For a quick photograph. Who's taking the photograph there? I hope the team members have taken the photograph. Thank you very much. Thank you once again for your valuable time. So this topic, that is psychosocial aspects of disaster, is a topic that warrants extraordinary discussion. So we would even have another mental health dialogue on climate change and disasters in the near future, for which we are going to have resource persons from the Department of Psychosocial Support and Disaster Management in hand. So see you all again. I thank all the members of the audience. We had more than 100 people who logged in, for sparing your valuable time. Thank you all. See you again.
Thank you.
Thank you, sir.